Okay, so wanted to talk about syphilis today for a couple of reasons. Number one, personally I find it to be a very interesting disease, but number two, that we're seeing in not only in Louisiana but all throughout the country, and in particular in the southeast, really high rates of not only syphilis but other sexually transmitted infections. And this is a disease that can have, if not treated correctly, can have lifelong impacts on people, including death. So let's go to the next slide. Okay, so just really quick, syphilis is a sexually transmitted infection caused by a bacteria called Treponema pallidum. This is a picture of it under what's called dark field microscopy. And you can see they kind of look like corkscrews. We call these spirochetes. Next slide, please. So I'm gonna, my initial presentation was very long. I went back and cut out a lot of things, but I did want to touch a little bit about the history of it. Again, I think it's interesting and it helps put it in context. So there are a couple of theories about how this disease originated. So the first one's called the Columbia hypothesis, and that's that the men that traveled with Columbus came back to Europe and brought this disease with them. And this is simply based on there's not really any evidence of this particular disease in the old world prior to the 1500s. And then the other hypothesis is that no, it existed for a long time in Europe before, but it went unrecognized. And maybe one of the reasons for the lack of recognition is that syphilis is known as the great imitator. It can present in many, many different ways. And so it might have been labeled as another disease without realizing it was the same thing. Next slide, please. Okay, and then this is just showing that, again, this disease has been represented and noted in almost as long as recorded history. So there's a wood carving on the left here. I think that's from the 1400s. It's probably hard to see on the slide, but you can see these the little chancres all over this guy's skin. And on the right, I think this one's from around the 1600s, and this guy is in basically what they called an oven, because that was one of the treatments that was suggested, was heating up the body and inducing an increased body heat to kill this disease. And by the way, that didn't work. Next slide, please. Okay, so the first recorded outbreak was in Italy in the late 1400s. And look, syphilis has always been a stigmatized disease, and every country had their own name for it, blaming someone else. So with this outbreak in Italy, it was labeled the French disease because the French were invading them, and also so the inhabitants of what is Italy today called it the French disease. The French called it the Neapolitan disease. The Russians called it the Polish disease. So you get the idea. This disease has always been very stigmatized, even back then. In the early 1900s, the causative agent was identified as Treponema pallidum. And this was the first, quote, new disease to be discovered right around the invention of mass printing. So the news spread really, really quickly. Early on, there was a treatment called salvarsan, which is an arsenic compound that was developed around 1910. And then penicillin was established as the treatment of choice in the early 1940s. Next slide, please. Okay, we already covered, that slide looks the same. Just a little bit more about the history. So mercury was proposed hundreds and hundreds of years ago. It did have some effect, but also mercury super toxic. And then again in 1910, the salvarsan was developed by Ehrlich. As I mentioned, it's an arsenic compound, so it's toxic, but was better than mercury. Fleming discovered penicillin in 1928, and again by the early 1940s, this was the treatment of choice. And I'm going to ask you to pay attention to that 1943 year. Next slide, please. Okay, so let's talk about the Tuskegee study. Probably everyone on this call is familiar with this to some degree or another. It was from 1932 to 1972, and it enrolled 600 Black men and just about 400 with syphilis. Now, the informed consent I mean, this is an understatement. Informed consent was not obtained for these patients. These men were told that they were being treated for, quote, bad blood. They were not, they were encouraged to not seek medical care outside of the study. And in fact, they weren't even told the formal name of the study, which was the Tuskegee study of untreated syphilis in the Negro male. So their intentions from the beginning were to not provide treatment. At the beginning of the study, there was no really good treatment for syphilis, but 10 years later, penicillin was the treatment of choice. These men were not told about this. They were not given the option for treatment. They were subjected to blood draws, lumbar punctures. Many of the men passed this disease on to their wives and girlfriends, and almost all the men who had the disease suffered extreme morbidity if they didn't die from it itself. The study was not ended until 1972 when the AP broke this story, and it took some time, once this got into the public consciousness to actually shut it down. Next slide, please. So in summary, the Tuskegee study is an often cited contributor to delays and avoidance in care, wariness of public health campaigns, and low participation in clinical trials among Black men. And compared to other demographic groups, Black men have the highest death rates from just in general chronic conditions such as HIV/AIDS, heart disease, cancer. So this is something that we see continuing to echo through modern healthcare. Okay, so let's take a look at current numbers. Next slide, please. And what we see is an alarming trend. So nationally, syphilis rates have climbed since the early 2000s, which was kind of the lowest point that we had seen it. Now we're seeing infection rates the highest that we've seen in like 70 years. And of course, in Louisiana, we're seeing this, and in fact, a higher rate. So from 2021 to 2022, we saw an increase of 24% in primary and secondary syphilis diagnosis. And that makes it 26.5 per 100,000 people of population. So much so that last year, the U.S. Department of Health and Human Services set up a national task force to focus on the regions with the highest burden of syphilis, and Louisiana is one of those 14 states identified. Next slide, please. Okay, and this is just a graphic representation of the same, showing the steadily increasing rates, in particular in the last few years. Next slide, please. Okay, so not only are we seeing higher rates of just syphilis infection in general, we're also seeing higher rates of congenital syphilis. So congenital syphilis is when a child is born to a mother with either undiagnosed and untreated syphilis or inadequately treated syphilis. And I had a lot of information on adequate treatment and things like that, but that's kind of beyond the scope of this discussion. So I took all of those slides out, but if anyone's interested, we can, if we have time later, we can talk about that. In 2021, Louisiana had the third highest case rate of congenital syphilis in the nation with 110 cases. And there were 115 cases the following year and 7 related infant deaths. So that's 1 in 490 live births affected by congenital syphilis. And here's the thing, this is entirely preventable. Next slide, please. So this is just a graphic pointing out the same. And then I also wanted to point out, no, that's the next slide, sorry. Next slide, please. Okay, we already talked about the definition. So again, if the child has physical laboratory radiographic signs of this disease, or if they were born to a mother with untreated or inadequately treated syphilis. So this places these infants by default in the presumed congenital syphilis category until workup proves otherwise. And again, really puts the impetus on these mothers that have come in with limited or no prenatal care, really ruling out any possibility of this diagnosis before the child goes home from the birthing hospital. And I'll point out that the most commonly missed care opportunity among these mothers linked to congenital syphilis cases was lack of syphilis testing in the 3rd trimester. Next slide, please. Okay, so this is kind of a busy graphic here talking about congenital syphilis in Louisiana. I just wanted to point out a couple of things that, so we see here on the left, Black women made up 62% of all cases connected to congenital syphilis. That was in 2022. And what was the other thing? About a third of them had a positive toxicology screen during pregnancy. All right, next slide, please. Okay, so just a couple of pictures, just because this can really help someone recognize what's going on. So we divide congenital syphilis into arbitrarily two categories. So early, which presents before age 2 years of life, and then late congenital syphilis, which you see the manifestations after 2 years of life. Now, 60 to 90% of children affected by early congenital syphilis are actually going to be completely asymptomatic at birth, and that's a huge amount. And it really puts the impetus on proper evaluation and treatment if indicated. So on the left here, we have a picture of what's called snuffles, which is a really extreme rhinitis or runny nose. And then on the right, we have the rash of syphilis, which again is typically not present in these babies, but if it's present at birth, it tends to be really widespread. Okay, next slide, please. All right, and then a couple of physical findings for late congenital syphilis. And again, I think this is helpful for anyone who works in any kind of healthcare, any kind of community care. If you see a child that has these what we call facial stigmata, it's worth raising an alarm and asking, hey, what's going on? Is this kid seeing a doctor? So on the left, we have, and it's kind of hard to tell from this front on picture, but frontal bossing, which is kind of an outward bowing of the frontal bone. We also see, sorry, it's called saddle nose. So the bridge of the nose is real depressed. And on the right side, we see what's called Hutchinson teeth. So these teeth are notched on the biting surface and they taper really down, taper as they go down towards the biting surface. And they're also typically smaller and widespread. Next slide. Okay, and then finally, we have what's called saber shins, which is anterior bowing of the shin. So the point of all these pictures and discussion is that syphilis in a newborn can affect essentially all organ systems and can cause physical changes that you can see in their bones. All right, next picture. Slide, sorry. Okay, so shamelessly, I stole this photo, this graphic from the very first presentation we had, but I just thought it was really great to kind of talk about the what exactly is health equity, what exactly is health equality. So health equity is achieved when everyone has an equal chance to be healthy regardless of their background. And every healthcare provider has a moral responsibility to advocate for equitable access to healthcare. All right, next slide, please. Okay, so let's talk about disparities. We already talked about the national trend in all of these case numbers going up. In 2022, about half of all cases at any stage of syphilis were among adolescents and young adults, so 15 to 24. In the same year, just under a third of all cases of primary and secondary syphilis were among non-Hispanic Blacks and African American persons, even though this group only makes up about 12.5% of the U.S. population. And then men who have sex with men are disproportionately impacted. They make up over a third of all cases of syphilis. Next slide, please. Okay, so this is just an infographic kind of showing what we just talked about. But again, it's worth mentioning 59% of diagnosis of primary and secondary syphilis, this was in Louisiana, were among Black people. And then in general, men make up about 2/3 of the cases. Next slide, please. Okay. And then this is just something that we already mentioned, but there are some further behavioral factors that we could talk about. And again, men who have sex or gay and bisexual men make up a large portion of the total cases in the state, especially considering their relatively small representation in the entire population. All right, next slide, please. Okay, and it's really important to remember when we're talking about equity that these higher rates of sexually transmitted infections in different racial groups are not caused by their ethnicity, their genetics, or their heritage, right? But they're due to social conditions that are more likely to affect these minority groups. So poverty, food insecurity, job insecurity, less jobs available, lower educational levels, things like that. Next slide, please. Okay, so why? Well, we already hit on one of those, right? So, and another important thing to think about is across the state, we've got many different rural areas, we have urban areas, we have areas in between, and access to health care is not the same in all regions of our state. And there's a few reasons for that. So, we're seeing budget cuts to the health systems. Often the young people, the adolescents and young adults that we're seeing many of these cases have not great health insurance. They're underinsured or uninsured. Also, there's been a lot of research showing that areas with higher rates of poverty also have higher rates of sexually transmitted infections. And then I read this recently. I thought that was kind of interesting. So some people have suggested that the growing use of PrEP, which is the preventative antiviral to prevent HIV infection, may also be contributing because people are perhaps less likely to use condoms because they think they're protected from HIV, but they're not getting the information that, hey, there are other sexually transmitted infections out there. Next slide, please. Okay. And then something that we talked about already. So historical events, with the Tuskegee study being among the most well-known and the one that's had probably the most impact, is that a lot of people in minority groups have experienced discrimination in healthcare due to their race or ethnicity. There is, a long history of cultural insensitivity that's caused these kind of deep wounds. And so it's thought that a lot of people have developed a lot of mistrust in the medical system as a whole. Next slide, please. Okay, and then specifically talking about congenital syphilis, because as a pediatrician, this is something that I'm particularly interested in. So in general, nationwide, there are 3.5 million births in the United States annually, yet rates of maternal morbidity and mortality are increasing. Why is that? Well, over 2 million women in the United States who are of childbearing age live in maternity care deserts, which is defined as an area without access to maternity care providers or birthing facilities. We're seeing this regionally, for sure in Louisiana, Mississippi. We're seeing smaller community hospitals either closing, getting bought up by bigger health systems, or if they're not closing, many of them are closing their labor and delivery units. So women have to travel further and further to get pregnancy care and then also to deliver. Next slide, please. And look, it's worth emphasizing that good access to maternity care is essential to preventing poor health outcomes in both the mothers and neonates. So maternity care in access in Louisiana, this is from the March of Dimes sites. So over a quarter of our parishes are maternity care deserts. And that's a lot, right? It's kind of mind-blowing. Over 10% of the women in the state have no birthing hospital within a 30-minute drive, and that's compared to 9.7% nationally. 16%, over 16% of women in our state receive either no prenatal care or inadequate prenatal care. That's twice the national percentage. And then something that we're seeing all over is that women with chronic health conditions have an almost 50% increased likelihood of having preterm delivery and other complications. So this little infographic on the left, further demonstrates this, that women in Louisiana on average travel over 3.5 times further than women with full access who don't live in a maternity care desert. All right, next slide, please. All right, and then I just thought this was a neat and helpful graphic here. So this is in the United States, congenital syphilis rates for 2022 broken down by race and ethnicity. And so we can see here that white mothers made up over 50% of the population of women who gave birth that year, yet contributed only about 27% of congenital syphilis cases. Conversely, we see that Black and African American women make up about 14% of this population, yet they had almost 30% of the congenital syphilis cases. So really kind of just makes that information kind of really hit you in the face there. Next slide, please. Okay, some other contributions. So, look, education is a huge thing, and sexual education is actually not required in our public schools. The state says that the schools can offer it, but not until seventh grade. New Orleans Parish is actually an exception here, and they can start in third grade. So, just in general, education on sexually transmitted infections is lacking for the general public. Also, there was a penicillin shortage that began in the later stages of the pandemic, and that's recovering, but it's still ongoing. And then the pandemic itself, certainly with just access to healthcare for a lot of people. Next slide, please. Okay, so what are some things that we can do to reverse this trend? I think, look, this is we have to take steps on many different fronts to start seeing these numbers change. But advocating for good legislature to fund outreach, especially in our rural areas. I'm, again, a proponent of increasing mandating sex education in schools, and then also to improve health insurance coverage options. We, of course, need to increase awareness and screening, which we'll talk about in a second. And then in 2016, Louisiana did implement a 9-region case review board, which was modeled after the state's HIV case review to review cases, in particular of congenital syphilis with case managers, and to kind of follow these trends and track these cases down. Next slide, please. Okay, so let's very quickly talk about screening. I know this isn't probably germane to most of the people on this call, but just to keep in mind. So for pregnant people, all pregnant women should be screened for syphilis, either at the first prenatal visit or during the first trimester, again, early in the third trimester, and then if they have certain risk factors, at the time of delivery. What's more is that no infant should leave the birth hospital without having documented serological evidence of mom's syphilis status at least once during the pregnancy. Even working in I live on the North Shore of Lake Pontchartrain. Even in that area, I would routinely, when I was seeing newborns, would routinely see moms come in with very limited prenatal care. They either had no screening, or maybe they had an RPR done early in the pregnancy. Finding out this information was challenging. You know, we would always get a screening test on the moms when they presented if we didn't have that documented already. But finding out the information from the OB standpoint, if they were having prenatal visits of, hey, was mom treated? Did they do another RPR titer? A lot of times these moms would just get sent to the public health unit, and I would be relying on, well, you know, the OB notes saying, well, mom said she went here and she got treated. So really trying to document all this information can be a huge task in and of itself. And then one thing that I thought was interesting is the point that, you know, clinicians who they're not OB doctors and don't routinely care prenatal care should also be invested in this. So if you're working in an urgent care and a pregnant mother comes in with an upper respiratory infection, just having that little bit of impetus to be curious and say, hey, mom, you know, are you getting prenatal care regularly? You know, have you been tested for syphilis, can go a long way. Next slide, please. Okay, so screening for non-pregnant adults, annually for all men and women if there are risk factors. All gay, bisexual, and transgender persons should be screened annually, and then also annual screening for people with HIV. Now, the Louisiana Department of Health I believe it was last spring, came out with some updated guidelines and said, look, we're seeing so much more syphilis. They didn't give any hard and fast rules, but essentially said, look, we need to do more screening. Next slide, please. And then finally, in adolescence, there's really no clear cut recommendations, which is a little bit disheartening. So the CDC and the American Academy of Pediatrics just say, hey, look, if you have an asymptomatic kid, there's not really a recommendation for routine screening. And instead, the pediatrician should just assess the local prevalence of disease burden. That kind of ties into what I said earlier about the Department of Health last spring issuing guidance saying, hey, look, they didn't address the adolescent populations, but I think it applies to them, especially since they tend to have a higher rate of just increasing screening in adult populations. Now, there are, speaking as a pediatrician, some barriers to screening these adolescents. So number one, these kids may have concerns about confidentiality, especially if they're coming in with their parent. Also, the pediatricians themselves may not be aware of these local trends. So getting out that awareness to them so that they know, hey, look, I need to start screening more. And then also lack of parental support, which is something that I have run into from time to time. And it's just worth mentioning that adolescents have the right to privacy for any kind of treatment or diagnosis of anything to do with sexual health. Last slide, please. I think the last slide. Okay, yeah, those are my references. How did I do on time, Chrissy? Okay, thumbs up. Does anybody have any questions?